Well, good afternoon. Thanks very much for joining us for another of Stanford's Maternal and Child Health Research Institute seminar series. This is a virtual seminar series highlighting the outstanding research in maternal and child health at Stanford. And we're so thankful you can join us today. Really, we have an exciting presentation today from the MCHRI Biodesign Faculty Fellows who are designing and the new innovations to improve health and healthcare. Next slide. But I wanted to then also highlight the upcoming series for the seminar series because it really is very diverse. The next month is going to be on September 14th, Novel Strategies to Prevent Gender-Based Violence Among Adolescents, a very important topic in today's environment. So don't miss that on the September 14th. Next slide, and then a whole list of these on the seminar series website, including a number of talks in October and then December especially from, for example, Melissa Bondi, the new population scientist chair who's recently recruited. So please don't miss these upcoming seminars. And then next slide, what I really wanted to point out was then Friday, November 6th is our virtual Stanford MCHRI Institute Symposium. This is an amazingly refigured virtual symposium with a week-long interactive poster session starting the first part of the week in November, or first part of November, keynoted on Friday of that week by David Williams, who's the Chief Scientific Officer of Boston Children's, really highlighting the stem cell biology network. There'll also be sessions on COVID-related research in maternal and child health, and an entire session on scientific advances in health equity and social justice to highlight some of the major issues of today. So please submit abstracts of your research on the website due September 21st. And again, look forward to this Research Institute Symposium the week of November 6th this fall. Next slide. This is our education committee. If you'd love to join it, please contact us. Or if you have suggestions for new seminar topics, again, please contact one of the committee members. And then today, we want to talk about, I want to just remind you that we're going to be sending out a survey from this seminar. So please complete the survey, give us your suggestions, helpful hints, and opinions about the seminar series. We'd love to hear from you. And today, I really want to highlight the Maternal and Child Health Biodesign Faculty Fellows. I'm going to hand it over to Janine Furch and Ryan Van Wert, but really to point out that the Faculty Biodesign Fellowship is an interdisciplinary biodesign fellowship from the Bayer Center for Biodesign. And sort of to illustrate that, Ryan is a clinical assistant professor in medicine, who's the associate director, and Janine Furch is a clinical assistant professor in pediatrics, highlighting the sort of interdisciplinary nature of the program. So Ryan and Janine, take it over from there.
Thank you so much. It is truly our pleasure to be here today to be able to share the amazing projects that some of our biodesign faculty fellows have accomplished over the past year. They go through truly an 8-month fellowship that often lasts longer because they continue their projects on. But we wanted to tell you a little bit about biodesign, and if there's anything that intrigues you here, our next cohort, we typically take 12 biodesign faculty fellows, which is open to anyone from the schools of medicine or engineering. And applications are due coming up pretty soon on August 28th with an info session in 2 days. So it's very, very timely. Also feel free to reach out to me. Our contact information will be on at the end if you're interested in applying for the fellowship this year or in the future. But biodesign in general, the vision truly is to be a global leader in advancing health technology innovation to improve lives everywhere. And there's a couple ways that we accomplish that. Next. This was our class last year and our instructors. And the mission of the faculty fellowship is to educate and empower health technology innovators to lead the transition to a value-driven innovation ecosystem. We know that value is extremely important, but something that we don't often learn about as physicians as well. Next. And so biodesign typically has a variety of different courses or fellowships. There's the flagship year-long fellowship that many people from around the world come to go through. There's undergraduate courses, there's graduate courses, we have global programs, and we even have programs for executives in around surrounding companies. Next. But what we didn't have until about 6 years ago was a faculty fellowship. And we realized that our faculty were such great resources that we were actually overlooking. So we started this faculty fellowship. Dr. Paul Wang actually started it with Biodesign. And we now take 12 fellows a year, like I mentioned, and up to 6 of them can be supported financially through MCHRI, which gives a great pediatric and maternal representation. Next. Biodesign has a great track record. In the years since it's been established, not just the faculty fellowship, but Biodesign at large, it started over 50 companies. There's over 1,400 full-time employees of those companies, and they've raised nearly $1 billion. But most importantly, they've treated over 3.4 million patients. Next. And specifically about the Biodesign Faculty Fellowship, we've trained over 62 faculty since 2014. Most of these faculty are actually brand new to Stanford, but there's very senior faculty as well. So it really ranges the gamut, whether it's early, middle, or late in your career. All are appropriate. Anyone from a clinical educator to an MCL line or the UTL line, they've all completed the fellowship and found it to be valuable in their research and their clinical pursuits. And like I mentioned before, we couldn't do this without the support of MCHRI, and we've had 16 MCHRI BFFs in the last 3 years and can support up to 6 a year. We always aim for gender and racial diversity, and I've had 14 women go through the program and 9 engineers. So it tends to be very physician dominated. Next. And you'll even see some of your colleagues here from a variety of different departments, but they span the gamut from surgery to psychiatry to pediatrics and all the departments. And I'll turn it over to Ryan now.
Great, and thanks for the opportunity to be with you all today. I wanted to spend a couple minutes talking about exactly what the biodesign process is. Next slide, please. You know, and it evolves around the traditional paradigm of what we call technology push, whereas where often there's a very interesting technology that's developed on the bench in a lab, and then there's a process of going and shopping the technology around for clinical applications. Next slide. And our thesis at Biodesign is that that's really not the right way to do it, that if you start with the actual clinical application, the need, and truly understand and characterize that need, the development of technology will flow much easier after, and ultimately will develop into a more meaningful solution for that clinical need than otherwise. And this is something we call need pull. Next slide. And the whole concept of the biodesign process really is based on the concepts that Stanford developed many years ago now, design thinking, which is where you ultimately empathize with an end user and then use their needs, and by defining their needs are able to develop a solution for their particular problem. Next slide. And this is very easy if you're developing a single solution like an iPhone for a single user. Next slide. But it becomes much more complicated when you're looking at a complex ecosystem that we live in healthcare, where the physician and patient are a very small part of a broader ecosystem that spans regulation, intellectual property, variety of payers, healthcare providers, lobbyists, investors, etc. So to deal with all of this complexity, next slide, please. The biodesign process is divided into 3 phases, what we call identify, invent, and implement. And we start with the identification phase, which is really where we're looking around and trying to understand large gaps in care, large opportunities for impact in healthcare, and going through a structured process to identify only the most compelling needs. We then move into what we call the invent phase, which is a free thinking way of generating new concepts and solutions for these, and then filtering them down through a variety of lenses to make sure that they have a translational opportunity beyond them. And then finally, the implementation is really about go-to-market strategy development that admittedly is less prominent in our curricular programs. We really focus on the identify and invent phases. Next slide. In terms of the Biodesign Faculty Fellowship Program, I wanted to spend just a moment talking about what the program is like, and then also letting you know about some of the upcoming dates if there is interest in applying for the upcoming year. Next slide. The program spans 3 quarters, and we align to the academic quarters at Stanford, the fall, winter, and spring quarters. The fall quarter is focused on some what we call a boot camp session to get everybody aligned and up to speed on some of the terminology in the process. We then support you through developing observations, clinical observations of gaps in care, and of starting to characterize some unmet needs that might serve as a launch point for the projects that fellows will take through the winter and spring quarters. Our winter quarters focus very much on that needs finding phase, going through that structured process I alluded to identify and hone those opportunities. And then the spring quarter, we shift into concept generation, and we bring in not only a variety of experts in the fields of intellectual property, regulatory, business model, but also robust engineering support and business coaching support through that process. Next slide. In terms of the timeline, we actually have an info session coming up this Wednesday evening. If you're interested in learning more about the program, we'll be talking in more detail about the aspects of the fellowship and specifically some of the changes we're making in light of COVID. The applications, it's a simple 1-page application that's due on August 28th. There is a process of getting departmental support for this, so please check those details on the website if you're interested, because there is a process there. We'll be conducting interviews in early September and have our decisions out for the coming fellowship year in mid-September. If you'd like to get more information on this, we have a website. I included the link below, but you can navigate to it easily from the main Biodesign website. Janine is available to answer any questions directly, and Emily, whose email is listed there, is another resource for any details about the process of applying or any issues you have with signing up for the info session. So I'm going to pass things over to Janine again to introduce our speakers. Thank you.
Thanks, Ryan. We have 4 wonderful fellows, and first up is Yael Grenez, who's going to share her presentation. She is a clinical assistant professor of pediatrics in the Division of Immunology and Allergy. I'm sure many of you have worked with her clinically. She is tackling a very challenging problem that she's quite an expert at around allergic reactions and trying to prevent anaphylaxis and admission to emergency department. So take it away, Yael.
I'm not muted, right? You can hear me? Just want to make sure. Perfect. Thank you so much for introducing me, Janine. So yes, it will be about detecting early sign of anaphylaxis. So about 32 million of patients in the United States are affected by food allergy. And a big percentage of these patients are children. And these children, upon exposure to common foods such as wheat, egg, peanuts, will develop acute symptoms that can be hives or angioedema, but can also be way more severe, such as anaphylaxis. So as you can imagine, the parents of children with food allergy fear a reaction. The food challenge that we do in our clinic is the best way to diagnose a food allergy. So usually a child will come to a clinic, will perform a physical exam, take his vital sign, and then we'll give him or her a tiny dose of what they might be allergic to. If nothing happened after 15 minutes, and if the physical exam remained normal, we'll give the child a bigger dose. And that will be going on for 3 to 4 incremental doses, up to 1 full serving. Would the child not react, then it doesn't have a food allergy to this particular food. Would the child react, and we can only see that with observation, we'll have to treat. And if I have to administer more than 2 EpiPen injections, I will have to call 911. We have a concern about the safety of the food allergy since recently some allergies reported the death of a 3-year-old boy during a food challenge. So we really need better tool to detect anaphylaxis during a physician-supervised food challenge. What about the incidence of anaphylaxis? Well, it's quite frequent and it has significantly increased in the past 10 years. So there is an increase by 2.3 visit to the emergency, and you have about 34,000 visits to the emergency. It's about 10 million of parents who are worried. And anaphylaxis is like an avalanche. The earlier you treat it, the best outcome would be. So our mission is a way to detect early sign of an allergic reaction in patients with food allergy or at increased risk of food allergy in order to decrease doctors and parental anxiety in managing anaphylaxis. Our solution must have a way to constantly monitoring our patients. We should have an alerting system that tells the patient to stop eating the food, or maybe it is time to give an EpiPen. It would be excellent at detecting early sign of anaphylaxis with a very good specificity and sensitivity. And it should offer a target window that would be about 3 minutes. It's so acute that I don't think we can provide any information more than 3 minutes prior to anaphylaxis. The nice to have would be, it should be customer friendly. It should cost around $400. It should alert the parents if the child is at school or in a birthday party. It should alert the physician of the child and hopefully address this barrier or fear of a reaction for the parents. How do you define anaphylaxis? Well, as I mentioned before, anaphylaxis is defined by a serious allergic reaction, and it's extremely rapid in onset. There is a definition primarily based on symptoms, but also on what was going on at the time the reaction occurred. I don't want to go too much in detail, but what I want you to pay attention to is there is respiratory, blood pressure, skin, GI symptom. So we hypothesize that if we study or if we monitor constantly the organ implicated in anaphylaxis, such as heart rate with a heart rate sensor, blood pressure with a continuous cough monitoring, oxygen saturation with an O2 sensor, respiratory, abdominal movement, skin color, skin impotence, we might be able to detect anaphylaxis before any clinical symptoms occur. So you already have seen these slides. As I mentioned to you before, we do a lot of food challenge. Some of the kids will react, some of the kids will have an anaphylactic reaction. Instead of, we'll still do a physical exam, we'll still take the vital sign, but instead of just observing, we'll now place device that will help us to continuously monitor them during a food challenge. And therefore, from an observation, we'll move to measuring objective sign. If I summarize a snapshot of the 3 developmental phases of this project, the first 2 phases will happen in our office under our supervision. So a patient, which probably will be older than 10 years old to be able to carry all these devices, will undergo a food challenge, but prior starting the food challenge, he will wear all these devices. They're a little bit bulky, they're not very convenient, they're definitively more platform research device, but they are the ones that can help us to detect a signal and then create an algorithm. The end goal is a phase 3 that will occur in normal life settings where a child could wear a customer device that is friendly and can wear it at all time when he's going to school or when he's going to a birthday party, for example. So if you look at over time, the first phase will be probably a uni-center pilot phase that will enroll about 20 patients. And really the goal will be to detect a signal. Can we see something? And what are the best sensors? Maybe not all of them are helping to identify anaphylaxis early on. But then when you know what the best sensors are, you can create a multi-center study. You can create an algorithm to predict anaphylaxis. It can potentially become a diagnostic tool. That's when you have an intellectual property. You will have to go over the regulatory pathway and then prototyping and then finally market and consumer product. How would that product be reimbursed? Well, it should be a one-time cost for the wearable device, which will be around $400. And This device will send daily reminder to tell the patient you carry your EpiPen. And then there will be a subscription, likely annual subscription of $100 per year. The phone will not be required to be with the patient, but it will allow us to update any refined algorithm, as well as it would be a very good way to upload some data from our patient. And because we keep sending this reminder about EpiPen, we hope that we'll be able to partner with the epinephrine manufacturer, as well as the doctor, the patient food community, and potentially big companies. So as a summary, anaphylaxis is acute and can be life-threatening. It is very frequent to have anaphylaxis when you have food allergy, and that is inducing a parental fear of a reaction. And we are concerned about the safety of a food challenge. So we need a better way to detect early objective sign of anaphylaxis before any clinical symptoms, which will help as a diagnostic tool to improve the safety of a food challenge in our office, but also to be a consumer product, which will help with the parental fear of a reaction. Just one more thing that Janet asked us, we always have to look at risk and mitigation. We thought about the risk, we find mitigation for all of them. I'm not gonna go through that, but I wanna thank everybody who helped us to do this fellowship. And it was awesome. And I wanna thank the Maternal and Child Health Institute who supported us. Thank you very much.
Thank you, Yael. And thanks for working on a project that is just a problem that's so ubiquitous in our culture right now. Food allergies are certainly a huge problem and not only create anxiety, but have a real clinical impact. Now for our second fellow is Dr. Ritu Asija. I have known her for a long time. She's a clinical associate professor in pediatric cardiology and a CVICU intensivist. And she also focused in an area that I know is near and dear to her heart that affects a lot of her patients, and that is around DVTs in patients with PICC lines. And so we'll hear from her now.
Great, thank you, Janine. Go ahead and share my screen here. Okay, can you see my screen? Okay, great. The title of my project was to look at new ways to reduce the incidence of PICC line associated DVT. And I think it's important for us to remember how much we use PICC lines, and they're becoming more and more common for us to use as our sort of first central line to go to in newly hospitalized patients. So this picture here is just a reminder of how commonly used these lines are. My needs statement is a way to prevent catheter-associated deep vein thrombosis, or DVT, in patients with PICC lines in order to reduce the need for systemic anticoagulation and preserve future vascular access. And this is important because the treatment for line-associated thrombus is usually Lovenox or some sort of anticoagulation for a short period of time, which of course has side effects associated with it. So it's just important to remember again, when we're placing these lines, that there are consequences sometimes of these lines. And of course, the more lines we place, and especially in our chronically ill children, and the more thrombi that they get, it really does threaten their future vascular access when oftentimes they need lines well into the future. I chose to focus in on PICC lines because, again, we're using them more and more, and they constitute approximately 38% of all the central venous line market. The central venous catheters that we use, sort of the IJs, the femoral lines, those are, of course, more challenging to place sometimes in an awake patient, and may not be our first go-to line in a patient who's otherwise stable. We don't use ports very much, except for children receiving chemotherapy and things like that, but certainly not in the intensive care setting. And then there's a whole slew of other types of lines we use, but of course this is the most commonly used line, and it's the growing, sort of biggest market that's growing. So 2.5 million PICC lines are placed per year in the United States. And there's a baseline rate of around 3%. The cost of a DVT is around $16,000. And when you do the math on this, the total cost to healthcare system for this iatrogenic complication is over $1 billion per year. The current therapies for this, there's a lot of companies that develop PICC lines. And the focus of these companies, Cook, Beckett Dickinson is probably one of the biggest, Angiodynamics. These are all catheter companies that have focused on preventing DVTs using different types of coatings, which also are geared towards preventing infections as well. ChloroGuard is one of them, BioFlow. These are all very high cost technologies with medium to low efficacy because they are not completely effective in preventing DVTs. Probably the most effective is just using best practice guidelines, using good insertion techniques and selecting a catheter that's small, the smallest possible catheter for that vein. Prophylaxis and different types of materials have given mixed results. So there's a gap, there's a big unmet need here where we can have a low cost but high efficacy way to prevent DVTs that are associated with PICC lines. In my must-have and nice-to-have criteria for this need statement, the goal is to reduce the use of systemic anticoagulants by 50%. We don't want to cause any bleeding or increased risk of infection with a new technology or new type of catheter. We want it to be usable by MD vascular teams, because non-MD vascular teams, because the majority of these PICC lines are placed by non-MDs. And we want the cost to be less than or the same as existing catheters. We don't want to cost the healthcare system anymore. And the nice to haves are all, of course, be nice if they didn't cause discomfort and usable in all sizes and ages and reimbursable. This is a schematic of how DVTs form. So thrombosis is a result of 3 different mechanisms that all come together. When there's venous stasis, there's hypercoagulability, and there's vessel wall injury. This occurs when the line's actually being placed, and then the stasis occurs because there's a catheter sitting in the vein. And then hypercoagulability is usually because the child is, or patient is relatively immobile compared to normal. So looking at studies of how clots form, in general, venous stasis occurs as a result of laminar straight flow through the endothelium. And I looked at different ways of changing blood flow patterns in order to reduce the amount of endothelial injury. This spherical or helical pattern of blood flow that happens in arteries at areas of branch points naturally in the body actually reduces endothelial activation by increasing wall shear stress. And this, I thought, was a very compelling, interesting idea that if we could apply this to the venous system somehow around the catheter, we could potentially prevent venous stasis and hence one of the contributors towards thrombus. This is a picture of a stent that was invented by this company, Biomimics, for peripheral vascular disease in the arteries. And you can see that the shape of it is purposely spherical or helical in nature to, again, promote a different type of blood flow, different than the linear blood flow. And so what I thought was that if we could make a catheter in the shape of this helical stent, that potentially we could meet all of our must-haves and our nice-to-have criteria. I don't know why it's not advancing. So looking at our risk analysis for inventing or innovating such a type of catheter with a helical shape, there's actually no obvious failure to operate with regard to the intellectual property. This type of catheter has not yet been invented, which makes me wonder why, if it's because it wouldn't work versus just that people haven't thought about this yet. The technical feasibility, we're going to undergo some studies, some modeling with Alison Marsden's lab, looking at different types of shapes of the catheter at the same size and do some modeling with regard to wall shear stress and see if we could actually reduce that number using different types of shapes and different types of helices. There's already a 501 pathway with predicates, and there's existing CPT codes. So in terms of developing this type of product, there's really very little risk associated with this. So the next steps are really to, for us to come up with some prototypes and some models of different types of helices, different types of shapes, and in terms of how these would be placed as well into the vein, to determine what the blood flow analysis is around it and whether or not this type of catheter compared to a straight cylindrical catheter could actually reduce the degree of venous stasis and wall shear stress in the vessel. So we will be undergoing those experiments shortly, and have started working on potentially a provisional patent as well going forward. So thank you very much, and thank you for joining us today. Thank you for the introduction, Janine, and I'd be happy to take any questions about this idea.
Great, thank you so much. And it's my pleasure now to introduce Anita Hunkanen, who is a professor in the Department of Anesthesiology, to share her presentation about her project.
Unmute myself. Good midday, I guess now. Thank you for coming and listening to this. I thought I'd step back and talk a little bit more about the class experience for everybody so you have an understanding of what that's like, and then just touch a little bit on my project. And I want to thank again the Maternal and Child Health Research Institute, Mary Leonard, and actually my chair as well, for supporting the time that I spent in this. And all the instructors are amazing. It's such a great experience. I hope you all have a chance to participate. So for my journey, the reason I was interested in doing this is that I actually come from a family of inventors. My dad both invented and manufactured surgical instruments, sold through Stryker and other companies. And several of my siblings were engineers. So I was the black sheep. And I've had a lot of ideas in the past. I can think of at least 3 that turned into, that over the years I've seen in companies that those ideas have been made into things. So I thought, well, how can I take one of my ideas and make it real? So that's why I was interested in this. And this gap and needs assignment part was kind of anxiety provoking for me. I think our prior speakers may have come into the class with a little bit better idea of an area that they already are interested in exploring. And I wasn't quite sure. I had some ideas, but I quickly discarded them and decided to open my mind. And so we spend several days in the fall looking at different areas of the hospital that you're not used to working in so much. And I came up with a few different ideas, we had one patient that almost had the wrong surgery one day because they had a language barrier and they came in and they were misidentified originally. I saw the surgeons struggling with neck and back pain from having to lean over with heavy lights stuck to their heads. The patients were being exposed at various inopportune times in the ICUs and in our OR suites, which I thought was unfortunate. And so whether you could come up with different gown type things, G tubes that were clogged, C arms that were really difficult to use in the OR. So there's a lot of gaps, and in the class they ask you to come up with a list of 15 or 20 gaps that you see during these observations. So if you're thinking about this, you might start looking around and thinking about that aspect of it. I actually didn't take any of these ones, and I came up with this issue, which I ended up following after a discussion with one of the nurse managers in the cardiothoracic ICU at Stanford. And she told me a story of a patient who had been in the OR from 6:30 one morning until 4 a.m. the next morning, continuously being coded and transfused, and ended up on ECMO with a variety of intubated and pressors, and was still immobile in the ICU. And when I dug into this a little deeper, up to about a quarter of patients that get cardiac surgery end up with some sort of pressure ulcer sore. And it turns out to be quite a problem in the pediatric side as well. So this is the area I decided to pursue, how to prevent pressure ulcers from patients that are in enforced immobility. And when you look at the patterns of adult and child pressure ulcers, you see that they occur predominantly over bony prominences where there's not a lot of fleshy padding. The circulation becomes somewhat compromised with prolonged pressure. I don't know if ever you've ever experienced this yourself. I used to be a flight surgeon in the Army, and when we would wear our flight helmets without communication gear in it, they're quite heavy, and we get hot spots very quickly on our scalp from the ischemia there. So it's something that happens fairly quickly. I explored various things about what the etiology was, so I could begin to think about how I might solve these problems. And one of the things I noted that was target pressure, less than 10 milliliters of mercury, capillary filling pressure, seems to be a target that you need to reach. So I came up with, this is my needs statement, a way to support the skin and soft tissues in immobilized patients in the critical care settings in the hospital, meaning the ICUs, ORs, to decrease the incidence of pressure-related injuries. And our other speakers have alluded to this. One of the processes that you go through when you have 15 needs statements that you're trying to decide which is the best to follow, one of the things that you do to help sort out is develop these must and nice to haves to understand if you can actually do something with this. And the must haves and needs, nice to haves help you hone in your thinking on prototyping as well. So in my must haves, I obviously want to decrease the problem, decrease the injury, either the incidence itself or severity. And there are very varying gradations, so the severity could be a good goal as well. It needs to be able to use it in an environment where the motion has to be controlled, such as the OR. And you don't want to increase the risk to the patient, and hopefully the cost is less than the current solutions that are out there. And there's nothing really that works for completely immobilized patients. Most solutions look to move patients in one way or another. There are several nice to haves as well that will address some of the other more minor etiologies for the issues, or make it more user-friendly in the OR or in the other environments, but the must-haves of acute issues. So then you go into once you've really, I mean, you spend a lot of time looking at your needs statement. I don't know if the other speakers want to speak to this, but it was both anxiety provoking and a little daunting, because we kept coming back over and over and over again, honing in. And it sounds very simple once you get down to what you have, but it was a arduous process, I'd say, to get to the needs statement that you want. And then the brainstorming is kind of a lot of fun. You get together with a group of engineers and other people, and you sort of kick ideas around. This was one of my ideas that I did not land on to try and prototype, but I thought it was kind of fun. It's almost like a little spacesuit that you could spray onto people, and with cushioning in between, so you'd have a uniform pressure on the patient. But you test all of your ideas against your needs statement, and that's why I have this slide up here. So you can see we have these must-haves with the checks that are yellow. It means that it didn't meet, I wasn't sure the solution would meet that very well, and the nice-to-haves as well. So you see, coming up with those statements are very helpful for your process. I actually, I'm going to stop sharing and just talk to you for a second. So at the end of the spring, we do a presentation, and I was lucky enough to receive extra funding for the summer. So I've been working on it all summer, in between being in the OR. And I've got some prototypes. I'm in the middle of putting my provisional patent application together, so I can't really speak to the details of what I'm coming up with until that's done. But it was a very interesting process prototyping at home. My living room turned into a little bit of a lab. It was a bit of a mess, but it didn't really matter because no one could come visit anyways. And now my garage, half of my garage is a prototyping lab. The other half, my daughter, who's home doing online learning for college, is using the other half for her schooling. And It's been a very interesting process. I've been reaching out to different engineers around the campus, around the Bay Area, getting some advice, getting to know different things, researching things that I never thought I would be interested in, but I'm enjoying it immensely, and it's exciting to see your ideas start to come to life. So that's all I have to really say right now, but I'm happy to answer any questions at the end of the process.
Great. Well, thank you so much, Anita, for sharing both your experience and some details about the project. It's really helpful to have that perspective, and thank you again, Ritu, for the great presentation. Well, our last speaker today could not, unfortunately, join in person, so we'll be switching over to a video. She was gracious enough to provide a recording. So now I will virtually introduce Dr. Kun Sheth, who's an assistant professor in urology.
Hello, my name is Kun Sheth. I'm a pediatric urologist here at Stanford. Thank you for the opportunity to present my biodesign project, the Directed Urocath. Now imagine this scenario. A child presents for a cardiac procedure. After induction, a Foley catheter is placed by the nurse, and the procedure is completed without any issues. But at the end of the case, it was noted that there was really no urine in the Foley bag. An urgent urology consult was called for this clear case of urethral trauma. The Foley had violated the urethral lining and been inflated in the wrong place. Luckily, urology was able to manipulate a catheter into place. But can you imagine going to sleep for a cardiac cath and then waking up to a completely different situation? This kind of trauma affects about 200,000 males in the US annually. The healthcare burden of such incidents is high, amounting to about $10,000 just in the hospital due to complications associated with urethral trauma, such as cystitis, urinary tract infections, septicemia, and surgical reconstruction in order to drain the bladder adequately. However, it doesn't even stop there. After leaving the hospital, up to 80% of patients need additional urologic interventions, be it cathing, indwelling catheters, or even urethral reconstruction due to fibrotic scar formation. Considering just the short-term hospital complications, the market for the device is large, with the potential to save $2 billion annually, amounting to $167 per catheter. Considering just the short-term hospital current solutions focus on avoiding incorrect balloon inflation while the catheter is still in the urethra, either by dedicated education or safety pop-off valves. There is one solution called PercuVision that actually is a directed placement of the catheter with a camera. However, it's very expensive. So looking at these current solution landscape, we can see that there is a clear need, an opportunity to find a way to direct catheter placement at a low cost. This brings me to my need statement, a way to allow urethral catheterization in male patients that decreases urethral trauma. The solution needs to be easy to use, requiring less than 5 minutes of time and can be understood by reading just a small leaflet. It needs to be inexpensive, and the cost here is based on allowing about a 50% margin with the use of improvement in trauma rates and therefore cost to the hospital. It also cannot increase the risk of UTIs, and it needs to decrease the urethral injury rate by about 50%. It would also be nice to have a latex-free solution that is adaptable to varying catheter sizes and intermittent catheterization while maintaining the same degree of drainage. The primary solution consists of a contact force detector at the tip of the catheter that can differentiate between tissue and open space. This information would be translated at the distal end force indicator, green indicating it's okay to proceed, red telling you to stop, and yellow saying that the catheter is now in the bladder. The exact mechanism of force detection could vary from a mechanical solution involving either springs or a balloon to an electronic solution. After correct placement of the catheter, the inner setlet can then be removed, activating the non-balloon anchoring mechanism. In such a way, we can eliminate both the source of urethral trauma, the balloon, and the inadvertent violation of the urethra by the catheter tip. Initial benchtop testing using various tubes and stiffer wires to translate the force to a force gauge taped at the distal aspect of the wire or catheter has shown a clear difference in the contact force that's present when the catheter is passed through the tube correctly, which is about 0.5 to 1.5 newtons, versus when it's actually pushed into the urethral urothelial wall, amounting to about 2.5 to 6 newtons. As a urologist, I can feel this difference in force when I'm passing a catheter myself, but it's hard to explain this difference when we're teaching other people how to place catheters. While there are some patents that are currently present for electromechanical feedback and tissue compartment sensing, none of these patents have anything to do with a urologic space, and therefore the IP landscape is quite open. On the other hand, the only one that has to do with urology is actually pressure sensing diagnostic catheters for urodynamics testing. From an FTO perspective, the claims that are currently present for avoiding urethral trauma deal with improper balloon inflation, but there's no claim that's really directed at catheter placement guidance. The regulatory pathway for this device is quite clear-cut, as it's another Class 2 device that can be passed through with as a predicate for other Foley catheters. And these requirements are pretty clear for both in vitro testing to show that there's adequate bladder drainage. Thereafter, the clinical trials to demonstrate efficacy in decreasing urethral trauma will be utilized to actually show that this directed urocath device is actually better at preventing trauma, and then lead to a second FDA approval for urethral trauma prevention. The current CPT and HCPCS codes for Foley catheter placement can be used for the directed urocath device, but in reality, most of these are often bundled in DRG and CPT codes for surgical procedures. So the key financial stakeholders are the hospitals and the surgery centers. Therefore, in this business-to-business strategy for this disposable product, the value proposition is crucial. While urethral Foley trauma is not yet a never event, it does lead to hospital-acquired UTIs, which is a never event. Furthermore, as the awareness of urethral trauma increases, there have already been incidents at Stanford itself where payers have refused to reimburse for hospital-related costs after a urethral trauma incident. So it's only a matter of time. The premium price of the product will be justified by the cost savings, and thus the key will be clinical evidence and support from patient advocates and nurses. Looking to the future, the early steps will be focused on further prototype development and testing, with provisional and utility patents filed along the way. This will then be followed by 510(k) clearance for bladder drainage in early 2022, followed by the pivotal clinical trial that will lead large-scale market rollout in late 2023, potentially expanding to global markets. Thank you for the opportunity to present my work, and please direct any questions you have for me to my email listed here below, chefk@stanford.edu. Thank you.
Well, that was an amazing set of presentations by the four BFFs for this year. I want to congratulate all of them for what amazing presentations and for enlightening us about the process that the Biodesign Fellows undergo. So I want to ask, we have a few minutes for questions. We have quite a few questions on the board here. And so I'd love to sort of first address this to Ryan and Janine, and that is, what fraction of the folks come in, the applicants come in already knowing what they're going to do, and how do you, what's the clinical immersion to find the unmet needs, especially during the COVID-19 crisis?
Yeah, so people come in from all of varieties of experience or lack thereof. So some people have extensive entrepreneurial experience, some people have very minimal, some people have started companies and they weren't successful, some people have just thought, I'd really like to get into a new area. So all are very welcome to apply. It's a competitive process, but as you can see, we take people from all across the School of Medicine and Engineering and any Stanford faculty, truly. And then the second question was a little bit around how do you do needs finding? So typically we pair up people who aren't in the School of Medicine with the physicians that are in our group. Ryan and I are both available to be shadowed as well. We will be taking this as a nearly virtual process, especially in the fall and winter. It will be fully virtual, although we'll be available on campus as we are, because we're practicing clinicians to meet with other people in small groups should that be necessary. We actually did the second half of this fellowship virtually last year, and it actually worked out pretty well despite the fears about prototyping at home. I know Anita spoke a little bit to that. We've really worked things out in biodesign to make it as smooth as possible and still allow us to have it be as interactive and valuable as possible as well. So we will be able to do some shadowing if all the appropriate compliance is adhered to. And then we have other ways that we access different clinical needs as well, through interviewing, through watching YouTube videos, and surveying, and a variety of other means as well.
Great. And then the question for Rita, and actually all for the other candidate speakers as well, it has to do with risk evaluation and validation studies and compliance. And so how much of that did you do virtually? How much did you do that in your garage or in a testing setting? How much from the needs assessment, how do you get to the compliance risk assessment type of a number which informs you whether to go for a go, no-go decision? So Rita, you want to start with that? Maybe we can go around to the other folks as well.
Sure. I was actually pretty surprised that one can actually apply for a patent without doing that. So it's hard as a physician, because I think you're used to thinking through things in a very systematic way, thinking, okay, I have to do a study to show that this is safe or that this works. And you don't actually have to prove that it works before you apply for your patent. So what you have to make sure of is that you're not infringing on somebody else's patent, and that the technology doesn't already exist out there. Once you do a really thorough patent search with the help of a good patent attorney and good helpers like Janine and Ryan and Partha, then you can really just kind of continue to move forward and continue to model your innovation in a way that hasn't been done before. And in terms of safety, of course, safety is important. For patient safety is important, but that gets done later on in the trials that you have to do in order to get FDA approval. So you don't want to delve into something that is going to be dangerous or something that could potentially have negative consequences for the patient. But it was surprising to me that you could move forward fairly far in the process prior to having to do those studies. And then of course you can always modify your technology to make it safer if it does cause any issues.
I needed a related question about how did you do how's your garage looking today? And have you thought about experimenting with warm fluid packs to achieve your objective?
Those are great questions. First, I've always wanted to dig into doing stuff with my hands and tools. So the garage is a mess, but I don't mind. I think it's great. It's a lot of fun. I actually was thoughtful about the safety aspects. So I have a large conference table that I'd already stuck down there for a variety of uses. And I went to Home Depot and got a big rubber mat that you're supposed to use on the floor as a safety mat and protect the table. And then I got some big tiles to put down to heat control, so they wouldn't cause any fires underneath these things that I'm using, the soldering iron and the heating vacuum mold equipment. So I had to got some safety goggles and UV light goggles and different things like that, safety gloves. So I'm trying to be careful about what I'm doing so I don't injure myself or anyone else that helps, like my daughter. So the garage is fine. As far as what was the second question? I'm blanking.
Or just about the fluid packs to achieve your.
Oh, well, in the brainstorming session, we talked about the fact that fluid would be ideal, and so fluid packs are a great idea. Warming and cooling, of course, can always be an issue in the OR in these places, and would help encourage vasodilation. So that's a great idea as well. When you look at the practicality of how to cover all the spots and relieve pressure, et cetera, that was the trick. There is a device out there that the Navy developed called, I think it's the dolphin bed or something like that, which has, many, many sensors, and it automatically evens out the pressure at every spot on whatever's lying on it. They've developed it for dolphin transport because the Navy uses dolphins for various underwater activities, and they have to transport them and protect them. So that device is pretty cool. It's very complicated, very expensive, and patients move when you're on it because it's constantly shifting them. So it wouldn't be practical for an ORN setting, but you're thinking along the right lines.
So maybe I'll have the person who emailed this question contact you directly.
Okay.
And then Yael, if you'd like to talk about how are you going to do more of the validation prototyping studies on the kids for this very important anaphylaxis prevention or alert.
I think the first step is really to see if I can detect anything. So it would be in patients who are reacting during a food challenge, can I even see a signal? I think that would be really the first step. And maybe not all the sensor will be indicative of objective sign before the anaphylaxis occur. And so it will be to detect the signal and then to really assess which sensor we could keep or not. And then it will be to apply those on more patients who are undergoing food allergy challenge, potentially double blind at that point, and then to really come up with hopefully an algorithm. It will take some time.
Yes. And then question for Janine and Ryan and also the group, what, assuming not if, but when these ideas become realized, what's the next step in getting them into or available to patients? Where is the funding coming from to commercialize these products? You mentioned a large number, many zeros after it of the success of the program. Where's all those zeros coming from for these successful BFFs?
Well, that's a great question, and I think I'll start off by saying that we do have what we call a summer extension program, and Janine mentioned this in her introductory remarks, which offers some not only financial support but additional support from biodesign faculty to bring these projects forward. There's also an incredible amount of internal funding that we're really fortunate to have at Stanford for translational grant opportunities, and I was really encouraged looking into those because there's so much that you can do to advance a project with the incredible resources that we have at Stanford, where a small amount of grant money can really have a multiplier effect due to those resources. Once it's ready to be translated outside of the university, it really does depend on what the project is, what the technology is, and what the overall opportunity is. And the pathways to commercialization vary from licensing arrangements with large strategic companies to a formal venture-backed company to everything in between. And I think that's one of the nice things about looking at the history of biodesign and the companies that have emerged from that program is that there is no one clear path, and there are ultimately multiple ways to get these technologies to patients depending on what some of those particulars are. There are, a lot of just being part of the biodesign community gives access to folks that can provide that type of strategic advice on moving forward in that regard.
And I would also just emphasize that it's not all about company development. We talk a lot about that because that's very tangible, but especially the faculty fellowship program. A lot of times these ideas catalyze as part of your research. We've had many different faculty actually get very large grants that are nationally awarded for the research that they started in the faculty fellowship. So if you're looking for, you want to cultivate an idea that maybe isn't anywhere close to being ready to build a company, but needs some incubation within the university, this is a really good place to start as well.
Yeah, I totally agree. I think we are very fortunate here at Stanford to have very tangible and expertise of getting both the basic pre-IND clinical stage, translational stage into patients. And that's really what the MCHRI is really, one of our goals is to really realize these ideas. And so the the program really is an amazing accelerator of that. Any last thoughts for potential applicants? For example, applicants, are you taking applicants from overseas, or just, questions before any other suggestions for or helpful hints for applicants? Brian, you want to take it?
Yeah, that's right. I was happy to start. So currently we do limit the candidacy for the fellowship to Stanford faculty, just by virtue of the, first of all, wanting to keep it a very high touch experience, but secondly, just due to the demand that we have for the fellowship. In terms of general advice, I think what, as Janine alluded to, there really are a variety of backgrounds in terms of fellows that come into the program. I think what is really important is to demonstrate that passion for medical technology innovation and how it can come to support better patient care, and particularly from a career development perspective, how health technology innovation can fit into the career path. So that would be one piece of advice I might give, but I'm sure Janine has a few others.
That's generally it. Are you passionate about medical technology? Do you want to make an improvement in patient care? And are you at Stanford right now? The other thing I would add is there are other programs that don't limit it to Stanford faculty. So if you are not part of the Stanford faculty, but perhaps want to apply for the year-long innovation fellowship, you can get information from that on the website as well. And that's open to anyone from any part of the world as well.
Wonderful. Well, I want to just thank Brian and Janine for what a great program that you guys are administrating, and congratulate this year's BFFs for outstanding ideas, and good luck to those developing them. And thank you very much for joining this today's seminar. I just want to refer you to the Biodesign Fellows program, also the information session in 2 days, and the deadline coming up for next year's fellows. So please apply if you have the least, the least bit interested. It'd be very nice to have you apply to this program. So thanks very much, and have a great afternoon.